Welcome to all the participants from every part of the world. We are spending an hour that will be well worth it with some of the best speakers in the domain of ophthalmology, speaking about technologies that are very pertinent to all of us in our daily practices. Actually, it is not a niche surgeries that we're going to speak about, and I think the idea of this seminar or webinar is for us to come out of it, each and every one of us having learned something. So without too much introduction and without losing any time, it is an absolute pleasure for me to introduce Dr. Vujosevic from the University of Milan, which is very near to where I'm working. I work in the University of Geneva, and I practice in the city and the canton of Geneva. So Dr. Vujosevic is going to speak about ocular hypertension and the 1-year results of multimodal imaging approach. Dr. Vujosevic, the floor is absolutely yours.
Thank you, Tarek. Thank you for this kind introduction. So first of all, I would like to say that I'm finding myself, I'm a retina specialist in the world of glaucoma colleagues. So I'm a long-standing user of the micropulse laser for retinal diseases since I would say 2010. And in the last several years, I have been using it also for the treatment of, let's say, early glaucoma or ocular hypertension, doing also the MLT. So it's my absolute pleasure to be here with you. Can you see my slides, just to be sure?
Absolutely.
Okay, thank you. Thank you very much. So these are my financial disclosures, none relevant to this presentation. Let me just look. So in this slide, we see these several milestones in the use of laser treatment of the trabecular meshwork. So first, it was obviously the argon laser trabeculoplasty introduced in 1979, and it causes non-selective tissue disruption and photocoagulation of the trabecula. Thereafter, almost 20 years later, the selective laser trabeculoplasty was introduced, and it is, let's say, less damaging treatment modalities, and it is definitely the most diffused trabeculoplasty technique used even today. In 2005, the micropulse laser trabeculoplasty, let's say, was reported at least of one of the first meetings of the FARVO, and this technique does not cause coagulative damage to the trabecular meshwork, and there is no blanching or bubble formation over the TM during the treatment. Let me move. Here you can see some images of the human eye bank eyes, where you see the coagulative damage of the ALT, the targeted cell lysis of the SLT, and you can see also this scanning electron microscopy after the treatment with the MLT that does not theoretically destroy the pigmented trabecular meshwork cells. If we see the features of these three different laser modalities, we can see the wavelength used for each of them. So MLT uses even longer wavelengths, even in the yellow spectrum, so 577 nanometers, and the infrared 810 nanometers. The mechanism of action, even if not still completely understood, but actually without thermal or collateral damage of the cells, it is a repeatable treatment, so you can repeat it even in the same session, I would say, and then thereafter. The treatment endpoint, you don't see anything. So this is the concept, for example, for me as the retinal specialist, where we are used when we do the retinal treatment with the micropulse laser, we don't see any sign, let's say, of the changing of the color on the fundus of the patients when we treat them, and even we do not see changes on fundus autofluorescence. So we are, I would say, quite familiar with this. there is minimal or none inflammation after the treatment. You can see the spot size is usually 300 micron and the complications are minimal or none. So here I show you my standard settings that I use with the laser IQ. So there are two 532 nanometers, but I mostly use 577 nanometer. So it is the Iridex laser. The spot diameter is 300 micron, duration 300 milliseconds with 15% duty cycle. So it is the longest duty cycle. In the retina, we use the shortest duty cycle of 5%. The power is set at 1000 milliwatt. It is always constant. I do not change it. And usually I do in the same session the treatment, if it is possible, of 360 degrees of at least 120 spots up to 200 spots. So if we think, do we need any treatment before, let's say, or after the treatment with the MLT in order to, let's say, reduce the possibility to have any intraocular pressure spike that you can have, for example, like with SLT after the treatment? Actually, it has not been shown that there is a need to treat these patients either before or after the treatment. So you can, let's say, avoid any treatment with the drops. So here, let me show you this video. So this is the MLT lens. Which is actually, this is the MLT lens, which is very easy to use and really makes it even more easy, the treatment. Obviously, you can use also, if you don't have this lens, you can use the Goldman 3-mirror lens for the treatment. So unlike the SLT, there are no the so-called champagne bubble when you do the treatment. So let me show you this very short video. So during the treatment, you don't see any changes and no champagne bubbles. So if we look at the EGS guidelines, when the laser trabeculoplasty can be performed, it is definitely, let's say, an early treatment. It can be done as the first-line treatment or together with the medical therapy and before the patients need the surgery. So the primary open-angle glaucoma, pseudoexfoliation glaucoma, or pigmented glaucoma are all the indications, possible indications, but also we can treat the patients even at the earlier stage of the disease. So when the patient has, let's say, only the ocular hypertension before the development of glaucoma. And it has been shown that the cumulative incidence of primary open-angle glaucoma development in the patients with ocular hypertension at 60 months, so after 5 years of follow-up, is of 4.4% in patients that are treated with, for example, topical medications, and it is more than double in if the patients are only observed. So definitely ocular hypertension is something we should think of, that these patients may need the treatment. So the indications for the laser trabeculoplasty, as I said, primary open-angle glaucoma, pseudoexfoliative glaucoma, pigmentary glaucoma, high-risk ocular hypertension eyes, and good candidates are the patients that have the contraindication to eye drops, that have poor adherence to medical therapy, that have significant ocular surface disease. Contraindications are congenital glaucoma, angle closure glaucoma, uveitic glaucoma, and neovascular glaucoma. So I think the selection of the patients is really very important. So if we look at this review paper of the efficacy of the micropulse laser trabeculoplasty in open-angle glaucoma. This review was done on 13 papers that evaluated the changes in the IOP after the treatment. So you can see that the mean change varied between, in these different papers, between 7.2 and 21.6% of IOP reduction, and that the retreatment was safe. If we think which laser we should do, MLT or SLT, so different papers you can see here, even the recent ones of a couple of years ago, show that the both treatments are effective and they do similar reduction in IOP. However, the approximately 10% of SLT patients experienced IOP spike post-procedure, and patients may have more discomfort after SLT when compared to the MLT. In this retrospective paper where patients were evaluated for 10 months, and this was a comparative study between the SLT and MLT, you can see how the IOP reduction was very similar. So almost 25% in the SLT group and 23.4% in the MLT group. So there was no difference in the efficacy between two types of laser. What is always the problem with the types of the treatment where you don't have a visible endpoint is the let's say the titration of the treatment. And it is that a lot of colleagues are, let's say, skeptical in how to perform the treatment, and the standardization is something very important. We have passed this in the retina world. We needed different years to introduce more widely the micropulse laser for the treatment of exudative macular diseases, for example. And I think also it is something important to say for the treatment also the trabecular meshwork. So the standard power should be used 1000 milliwatt, 15% the duty cycle. The number of the spots should be at least 120. And it was seen that when you compare the 100 versus 120 spots, there is actually 25% more IOP reduction if you use this higher number of the spots. So up to 200 spots is definitely something you can do without, I would say, any problem. So now I want to show you some data of our study that was presented at the EGS Congress in 2024, where we evaluated the MLT trabeculoplasty in ocular hypertension. And we evaluated the changes in intraocular pressure and also the multimodal imaging of the retina and the functional parameters. So we wanted to understand, let's say, how better we can manage the patients, let's call them healthy or with ocular hypertension, that are at risk of developing glaucoma. And we wanted to see what are the changes of anatomical and functional retinal parameters. So the patient population was the adults with the ocular hypertension, IOP superior to 21 millimeters at baseline, no previous history of trabeculoplasty or filtration surgery, and no significant other ocular diseases. These patients were then followed, the treatment group was followed prospectively for 12 months, whereas the control group of the patients with ocular hypertension that were not treated were the patients already available in our clinic, and we had the electronic medical record. So it was, this part of the study was retrospective, but let's say with all the follow-up. So the primary outcome was the mean IOP reduction and the percentage of subjects with IOP reduction that was equal or superior to 20%. The evaluation of the multimodal retinal imaging, the number of IOP lowering drugs, and we evaluated if there were the adverse events for example, including IOP spikes at 2 hours after the treatment. So the multimodal evaluation included the evaluation of the IOP, like 4 daily misurations, the tonometric curve, the evaluation of the OCT parameters, so retinal nerve fiber layer thickness and ganglion cell complex, the OCTA angiography parameters, the vessel density and the perfusion density of macula and papilla, then the functional parameters. So it was the perimetric parameters, the standard visual fields, 24.2, the mean defect, and also we evaluated the microperimetry parameters with the macular sensitivity, mean macular sensitivity, and the presence of relative scotomas. The images of the OCTA, that OCTA was evaluated in the macular lesion, in the macular area on 6x6 scans, and they were binarized for the evaluation of the perfusion density. You can see it is the center image, and they were skeletonized in order to evaluate the vessel density, so the image on your right. So the parameters are our standard parameters that I already mentioned. We use the IQ 577 nanometers, spot diameters 300 microns, duration 300 milliseconds, power 1000 milliwatt, and 15% duty cycles, 360 degrees treatment with at least 120 non-overlapping shots. You can see the medication, just the pre-op was the anesthesia and the pilocarpine, and the post-op non-treatment. Here you can see that we involved 43 eyes were treated and 27 eyes were the controls. You can see that the baseline characteristics were similar between the treated eyes and the control eyes. So the age was similar, female-male ratio was similar, central corneal thickness was similar, and also the percentage of the pseudophakic patients. Here also you can see the number of the IOP lowering drugs and the use of the IOP lowering drugs was similar and remained unchanged throughout the 12 months study period. So if we look at the changes of the mean IOP, you can see that at 3 months, there was a significant decrease of 17.4% at 3 months, 19.2% at 6 months, and 70% decrease at 12 months. The IOP reduction of more than 20% was achieved in almost 31% of the eyes at 12 months, while an IOP lowering effect of 15% was obtained in almost 60% of cases at 12 months of treatment. Here you can see the macular parameters, so the multimodal imaging parameters. At 6 and 12 months, the ganglion cell complex thickness values were comparable to baseline in treated subjects and significantly reduced in the control group. And in subjects receiving MLT, macular OCTA parameters, so the vessel density and perfusion density, showed significant improvement at 12 months. The visual field parameters, both those functional parameters of visual field and the retinal sensitivity and optic nerve head parameters, so the retinal nerve fiber layer thickness and the vessel density and perfusion density that were performed of the optic nerve, did not show any significant change during the 12 months of follow-up, and none of the subjects diagnosed with ocular hypertension showed progression to glaucoma. We did not record any serious adverse events and IOP spikes following MLT, as you can see here from the table, and a total of 36.8% of subjects experienced at least one non-serious MLT-related events, I would say very mild adverse events. And they were self-limiting and resolved within a couple of hours after the treatment. So to conclude, I showed you some data both in the literature and our own data on the efficacy of MLT in, for example, ocular hypertension eyes. Also, this is definitely the safe procedures that can be easily done in everyday clinical practice. It is very important to select very well the patients, and that is based on our, I would say, clinical experience. So the good candidates for MLT are patients with open angle, with ocular hypertension, with early glaucoma, naive to the treatment, with the drugs contraindication and poor compliance to the medical therapy. Bad candidates are patients with advanced glaucoma and with multiple chronic therapy. With this, I have finished and I thank you.
Thank you very much. That was very interesting, Stella. Can I please ask you to answer in a very short sentences the two questions that we have? One is MLT safe in secondary glaucomas, such as uveitic glaucomas? That's one question. And the second question is, would you prescribe topical steroids after MLT as we usually do after SLT?
So let me start from the second. I never prescribed the steroids after the MLT, and we really have not found any IOP spike due to some inflammation after the treatment. So I definitely do not prescribe it. The secondary glaucoma, I don't want to say it is not safe, because this is a safe treatment. Maybe it is not efficacious. It is not efficient. How to say, so that's something. So the secondary glaucoma is not one of those that, let's say, are the most indicated types of glaucoma to be treated with the MLT.
Thank you very much. I think for the sake of time, we move to our second speaker, Dr. Ronald de Crom from the University of Maastricht. He is going to speak to us about the long-term efficacy in glaucoma care of micropulse. Ronald, please.
Yeah, thank you, Tarek, for your nice introduction. These are my financial disclosures. Nowadays, if we look at all the different glaucoma treatments we can offer patients, there is a majority of treatments possible. And in this presentation, we are focusing about the glaucoma treatments, especially the micropulse transscleral laser treatment. And for the treatment, we can use the Cyclo G6 laser system. It's a system which uses one of 810 nanometers diode laser, and you can perform two different types of cyclo procedures. You can produce a continuous wave mode procedure, and you can produce a micropulse mode. Now, the continuous wave mode is standardized with an energy delivering in which the laser energy is delivered in a continuous wave. And if we compare that with the micropulse mode, the laser energy is delivered on the ocular tissue with intervals. So 1/3 of the time, the laser energy is applied to the ocular tissue, and 2/3 of the time, there is a pause of energy. And in the presentation after mine, Ziad will discuss some more indications about the continuous wave mode. But we know that also from the past that the continuous wave mode can be used in advanced stage disease, patients with poor visual potential, or after field traps, troops, or poorly controlled neovascular glaucoma. Also the micropulse mode you can use for this type of patients, but you can also use the micropulse mode in patients with milder glaucoma or better visual acuity. So in 2022, we've made some consensus panel guidelines in which we described good indications for treatment with micropulse transscleral laser therapy. So one good indication for treatment are patients which are not suitable for glaucoma surgery. or who don't wish to undergo incisional surgery. For example, because the conjunctiva is from bad quality, patients with ocular comorbidities. You can think on patients who are aphakic, in which we know that there is a higher chance of complications during surgery or afterwards. Also elderly patients, in which you know that sometimes postoperative visits are not very easy for them. You can think about micropulse laser surgery. Also, if you have a patient which already have had trabeculectomy or tube implant, but still has suboptimal intraocular pressure or a lot of medication, also that patient category is a good patient category in which you can consider the use of micropulse TLT. And you can also use it to bridge towards incisional surgery if you have to gain some extra time, if you cannot perform bigger surgery at the moment and you have to bridge a couple of days or a couple of weeks, you can consider bridging that time with micropulse treatment. And overall, if you've got patients with a stable glaucoma, with a lot of glaucoma medication, especially if they also need oral carboanhydrase inhibitors, you can offer them micropulse TLT in order to gain some medication reduction in these patients. Also in the guidelines, we have recommend some starting settings. If you use the revised micropulse P3 probe, we know that if you want to start and you want to deliver a primary treatment, the settings have to be at 2500 milliwatts and a duty cycle of 31.3%. You can't start with 4 to 5 sweeps of 20 seconds if you have a hemisphere approach and 10 seconds for sweep movement if you use a quadrant approach. But you can adjust the treatment settings, and that's an important thing. You can, for example, change the way the energy delivery is done towards the ocular tissue. And you can adjust the settings by increase or decrease the power, the sweeping speed, or the number of sweeps you use. So 2 examples. For example, you can do some more number of sweeps, for example 6 to 8 sweeps of 20 seconds per hemisphere, or you can make the sweeping time a little bit slower. So for example, instead of 20 seconds sweeping time per hemisphere, you can use 30 seconds of sweeping time. And it depends on patient-related factors, the amount of IOP, the severity of glaucoma. You can adjust the settings in order to get a bigger or a safer response. We also know that a couple of patients will need a retreatment or an enhancement afterwards. We know that overall there is a 60 to 85% success rate of micropulse TLT at 1 year. But we also know that 1 to 46% of the patients need an extra treatment depending on the duration of the follow-up. And there are different types of retreatments. So for example, if the first procedure was very successful and the treatment effect fades away after a couple of time, retreatment can usually be done with the similar parameters you used at the first treatment. But also if the first treatment was not successful, you can make an enhancement with some higher energy settings. An increasement of treatment time or a slower sweeping time. And also here 2 examples. One patient, if you've got an initial treatment with the parameters I mentioned in the slide, and the patient has a good result, if the effect fades away 2 years after the treatment, you can consider a retreatment with the similar parameters. On the other hand, if you got patients with a minimal treatment effect in the first 2 months after primary treatment, you can consider an enhancement. but I recommend performing it with some higher parameters. So for example, you can make the number of sweeps a little bit higher, or you can adjust the sweeping time. During the treatment, also a couple of things are very important. So during the treatment, you have to use some fluid interface to make a good contact between the probe and the ocular surface. You can use a lid speculum if you want to. And the most important thing are the last 2 points. So the probe orientation is very important. So you can see it on the picture to the right bottom. It's very important to position the bunnies towards the limbus, and during the treatment that you have a consistent pressure of the probe on the globe to make a proper contact. Now, nowadays, a lot of studies are delivered in which micropulse TLT is evaluated. And in the last part of the presentation, I will take you to some long-term efficiency endpoints of the micropulse TLT. So there are a couple of studies which reported the 2 years outcome of micropulse TLT. One of the studies from our own group, and after 2 years we found an IOP reduction of almost 30% in combination with also a significant medication reduction. In 80% of our patients we could stop the Diamox, and it was a very safe procedure with very few complications. Also, in the study of Chen et al., there was a good IOP reduction after 2 years and also a significant medication reduction. And if you look at the last study, also there we can find after 2 years a very good IOP reduction and high number of patients which could stop with the oral Diamox and also a very low complication rate. And last year we reported our outcomes in a 5-year analysis of micropulse transscleral laser therapy. And we investigated the outcomes of 165 eyes, both eyes with primary and secondary glaucoma. And in this slide, you can see that both the primary glaucoma patients in the blue and the secondary glaucoma patients in the red, during the 5 years of follow-up, both on the IOP level and medication level, we found significant lowering of both intraocular pressure and medication after 5 years. If we look in some more detail, we can see that in the total cohort, we still have to use some retreatments in the patients. And you can see that most of the retreatments are done in the first year. And of course, also additional glaucoma surgery is necessary in a small part of the patients. Some more in the secondary glaucoma patients in comparison with the primary glaucoma patients. If we look at the 5-year cohort from our study, and we are looking to the patients with only received micropulse laser treatment, also there we can see that during the 5 year, the intraocular pressure became very low in comparison with preoperative levels, and also the number of medications during the 5 year remained stable. So during the 5 years, the mean intraocular pressure reduction in this group was around 30%. And also, this was a very stable level. Also, if we look at the patients which has to use oral acetazolamide, there was a great reduction in patients after 1 year, and which also remained stable during the years thereafter. And just what you saw on the previous slide, you still have some patients in which you have to do a second treatment in order to get good results. And also here you can see that majority of the retreatments has to be done in the first year, and afterwards it remains quite stable. So if we look at the results of the 5 year, we can still see that in a large proportion of our patients, we can get stable IOP reduction up to more than 30% in combination with also a stable medication reduction. And also in our cohort, it was a very safe procedure with a low complication rate. Here I've got a clinical case, and there was a female patient of my 46 years old with pellucid marginal disease, open angle glaucoma, and already a glaucoma implant, a good visual acuity, and you can see the visual field to the right, and an intraocular pressure of 80 millimeters mercury, with, you can see it also on the slide, a lot of glaucoma medication. And what would you do with this type of patients? Do you add an extra topical medication, for example, prostaglandine? Do you want to perform a second glaucoma implant, or do you want to perform a ciliary body procedure? Now, in this patient, we performed a micropulse TLT, and here you can see the results. So you can see that the intraocular pressure responded very good on this treatment, and during the 5 years, the intraocular pressure remains very stable, and we could stop with both the brimonidine and the oral acetazolamide. And during this time, also the visual fields remained very stable. So in summary, a micropulse TLT has multiple treatment indications. It is important to use the proper baseline settings, but you have also the ability to increase or decrease the power settings, the sweep velocity of the number of sweeps, depending on the severity of glaucoma or prior treatment outcomes. And we know that there can be a long-term efficacy up to 5 years with a good intraocular and medication reduction at a very safe and low complication rate. That was what I want to tell you about the micropulse treatment.
Thank you, Ronald. That was excellent. Ronald, we have a few questions for you, but for the sake of time, we need to go very, very fast. First question, have you observed any drop of vision with a micropulse treatment?
Yeah, that's a good question. In our both studies, we found some vision changes, but majority of vision changes were due to other problems in the eye. So, for example, due to cataract formation, due to preoperative already existing retina problems, or glaucoma progression.
Okay. We have another question regarding anesthesia. What type of anesthesia do you use?
Ourselves, we prefer subtenon anesthesia or retrobable anesthesia.
Okay. One other question from Dr. Ali El Sheikh from Oman. Are you using 300 microwatt with very high IOP, as in more than 40 millimeters on full maximum medical therapy?
Yeah, you can use it, but we know the higher intraocular pressure is, the higher the chance that it could fail. So if the patient is in my office, I would certainly offer them treatment with micropulse TLT, but I adjust my settings with a higher sweeping number and a higher duration.
We have another question from one of the glaucoma gurus worldwide, Professor Tanush Dada, who is asking you, will this treatment and further retreatment cause conjunctival changes and increase risk of future filtering surgery?
Yeah, also that's a good question. With the revised probe, I've never saw it. With the original probe, which is a little bit sharp at the edge, in theory there could be some conjunctival problems, but both with the original probe, but also with the revised probe, we never saw some scarring of the conjunctiva, and we could perform a trap or tracer flow or a microshunt, for example, afterwards if it was necessary to do.
Another question from Professor Al-Nahrawi from Cairo, Egypt. Can you use it for eyes that are vitrectomized, filled with silicone?
Yeah. So also in our sub-analysis, we found that eyes with secondary glaucoma after vitrectomy, they are most of the time good responders to micropulse.
One last question. How long do you wait before you decide if retreatment is needed?
1 month. So with micropulse treatment, after 1 month, I see what the response rate is after the primary treatment. If I've got no good response rate, I consider a retreatment in the next couple of weeks.
Still have more questions, but for the sake of time, I think we should move on, if you would allow me, to Professor Ziad Khoueir. Professor Khoueir is head of glaucoma in the specialist eye and ENT hospital in Beirut, Lebanon. Ziad, please.
Okay. Thank you, Tarek, for the introduction. So today I'm going to share some pearls on continuous wave cyclophotocoagulation. Those are my financial disclosure. Just before starting, I want to remind you that in about 2 weeks, we have the World Glaucoma Congress in Hawaii. Iridex is organizing a wet lab there. So you can use the QR code to register for this very interesting wet lab. The WGA is also launching the mentorship program. This is a great initiative from the Associate Advisory Board aiming at fostering and encouraging research and freshly graduates in developing countries, especially in the MENA region, for example. So you can get more information on the WGA website. So I'm going to start with this slide. This is a figure that was taken from a paper from Pradeep Paramula that was published in Ophthalmology. And you can see here the total number of cyclodestructive procedures performed in the US during about 2 decades. And you're under the impression that those numbers are on the rise, but this is actually misleading. Those numbers are on the rise because of the introduction of endocyclophotocoagulation. But if you look at the numbers of transscleral cyclodestructive procedure, their numbers are steadily decreasing. And this is mainly because the classical transscleral diode has a very bad reputation. It has been associated to so many sight-threatening complications like hypotony, phthisis, sympathetic ophthalmia, and even chronic inflammation. And in this presentation, I'm going to share some pearls to try to make this procedure safer in our hands. So as we know, the most dreaded complication is hypotony or phthisis even. And we know also studies have shown that the amount or the extent of IOP reduction that you get in cyclophotocoagulation is proportional or proportional to the number of laser burns that you apply during the treatment. It's not only about the number of laser burns, but it's also the total amount of energy that you deliver during a cyclophotocoagulation session. So the first pearl to make your procedure safer and avoid hypotony is to use conservative parameters. So don't go crazy with your settings. Be conservative because hypotony can be irreversible and it's one of the main complications, especially in patients with neovascular glaucoma. We know that the majority of indications of diodes in our clinical practice are patients with neovascular glaucoma, and those patients are at a higher risk of developing hypotony when compared to other glaucoma subtypes. So as we said, the pressure can go very low after cyclophotocoagulation, but it can go up. And we tend to underestimate the occurrence of spikes that they can occur in up to 30 to 40% of our patients. And we're not talking about, small spikes of a couple of millimeters of mercury. The average spike is about 10 millimeters of mercury, which can be extremely detrimental to those patients with advanced glaucoma and with extremely compromised optic nerves. So we talked about the energy level. The more energy you put during the session, the better IOP reduction you're going to have. But it's not only about the energy in terms of numbers, but it's also how you deliver that energy to the tissues. And when we talk about photothermal mechanism, when you're heating a tissue with a laser, it's all about the gradient of temperature. So you start heating the tissue, you get hyperthermia, Then you get coagulation at about 60 to 80 degrees. Then you get carbonization at around 100 or 300 degrees. And then when you go above 400 degrees Celsius, you get what we call vaporization. It's when the solid tissue becomes a gas. And this is when you get the pop during cyclophotocoagulation. And we used to look for the pop. This was the classical approach, trying to heat the tissue until you hear the pop, but the pop is not actually a good thing, because pop means that you are getting vaporization in the uveal tissue, which means that you are creating a cavitation bubble, increased uveal antigen exposure, and this will lead to chronic inflammation, postoperative hyphema, and a high risk or a higher risk of complication for your procedure. So instead of delivering the energy quickly in a burst and getting a pop, the new tendency is to do what we call a slow burn, which is slowly cooking the ciliary body like you would do with a very gentle or light candle. And studies have shown that this approach, the slow coagulation approach, will give you outcomes in terms of efficacy that are comparable to the classical POP approach, but with a better safety profile, and namely a lower risk of getting prolonged AC inflammation. And the way to do a slow burn or a slow coagulation is to actually apply each spot for about 4 seconds with very low energy, around 1 to 1.2 watts per laser spot. So we talked about slow burn or slow coagulation. I'm going to talk now about transillumination. We all have the tendency to think that the ciliary body is a perfectly circular structure around the limbus, but this is actually not true. There's a wide variability of anatomical configuration between patients when it comes to the ciliary body, and the distance between the ciliary body and the limbus is not the same in all quadrants in the same patient. And this is why transillumination is something that is extremely important, especially when you have patients who had congenital glaucoma, high myopes, or any kind of surgery involving a peritomy. You look at the eye and you don't know exactly where the limbus is or where the ciliary body is. And the good thing about the new G6 platform from Iridex is that it also is compatible with what they call the G-Probe Illuminate, which is a G-Probe that also has an integrated light that would help you with transillumination. I'm going to show you a case that I actually did yesterday. This is the G-Probe Illuminate. You can increase and decrease the red beam of the laser and also the white beam of the transillumination and play around with it. Then what I do is that I use the probe to transilluminate and I do the marking on a dry surface. And you can see I do it 360 degree. And then after I've done that, I apply a coupling agent on the eye. I'm going to talk about this later on. And I spread the coupling agent using the tip of my G probe. And then I apply the laser burn. You can see the marking that I did for transillumination. I apply the laser burns using a slow coagulation approach. So the probe position is key. You need to be located at the level of the ciliary body posteriorly, because if you treat way too anteriorly, you will deliver laser energy to the root, to the iris root, and this will create chronic inflammation, anterior uveitis, and even pupillary distortion in some cases. Treatment technique is unfortunately underrated in cyclophotocoagulation. We all have the tendency to think that, you know, this is a laser, it's not surgery. Any first-year resident without any training can perform it, but this is actually not true, because when you deliver laser to a tissue, part of the laser energy is going to be absorbed and another part of the energy is going to be lost. It's going to be reflected, diffracted, and it's not going to contribute to the IOP lowering. And just by the amount of pressure that you put on the sclera with the laser probe, you can significantly impact the ratio of laser energy that is going to be absorbed by the tissue as opposed to the amount of energy that you're going to lose, and this will have a significant impact on the laser absorption and therefore the outcomes in terms of IOP lowering. You also need to use a transparent coupling agent when performing cyclophotocoagulation, because using a coupling agent, a transparent coupling agent, will also increase the energy absorption at the level of the ciliary body, and this will also translate into increased efficacy. So to summarize, to sum it all up, just by combining all those spurs, you can get the better safety efficacy combination when it comes to cyclophotocoagulation. And to conclude, I like to compare the experience of a cyclophotocoagulation to a dining experience. The classical approach, getting a pop, cooking the ciliary body quickly, is kind of similar to what you see here to the left, which is a fast food cuisine. But what we really want here is a slow cooking method using a coupling agent, not underestimating the technique that is behind cyclophotocoagulation. And as you can see to the right, the setting here is not okay. What we need for a good cyclophotocoagulation is a good setting, a good lighting, a good trans illumination, and only by combining all this you can get, what we call the 3-star Michelin experience that will give to the surgeon the best outcomes in terms of IOP lowering, and that would give to the patient the best safety profile in terms of quality of life. Thank you.
That was an exceptionally good talk, Ziad. Thank you very much. And I love the gastronomic aspect of it. A few questions. We still have a good 10 minutes for all participants to send questions and get answers from the experts. So one question is from Dr. Bozic, who is asking, is there a danger of losing visual acuity in terminal glaucoma cases, where obviously in advanced cases where very little vision is still available from intraocular pressure spikes? You have alluded to the danger of the spikes, and any glaucoma surgeon is always worried about the last few fibers in an optic nerve, if they would go away with a spike after surgery.
Yeah, definitely that risk exists in any glaucoma procedure. And even when you do nothing to a patient with a very advanced glaucoma, they can come overnight having lost the very few fibers that they have left. But whenever you perform a procedure, when the pressure goes too low or the pressure goes too high, you're at risk of having vision loss, and this is the unfortunate reality of advanced disease.
So we have another question that is, I will rephrase it actually, because I think it's very interesting. What are the chances of a patient stopping medical treatment altogether after doing such a procedure? And maybe we twist it a little bit. What do you promise the patient before surgery?
Are we talking about micropulse
PLT,
or?
Well, give us an answer on micropulse and CBC. You are well versed in every technique related to cyclomodulation. So let me ask you that. What do you promise, or how do you manage the expectations of your patients regarding stopping medical therapy? I mean, that is a question that comes comes before any type of glaucoma.
Yeah,
But then
I never take the conversation there. It's all about managing expectations. I never promise that the patient's going to be medication free, or that the end game is reducing the medication. Usually, when the patients reach that point, the unfortunate situation is that the IOP is not controlled, and they are at risk of losing vision if it stays uncontrolled. So the conversation is steered towards, we need to control the pressure in order to preserve your vision. And I don't venture into, this lowering medical treatment field. Even when I do tubes also, because as you know, when you do tubes, the rate of complete success or qualified success, is quite significant. So promising a patient that they will stop their meds is a bit of a risk in my opinion.
I mean, obviously, managing, as you said, managing expectations is key, and agreeing with patient about what is the definition of success is something that is also very important. We have an anonymous attendee asking, which is better, diode or cyclo G6 probe for transscleral cyclophotocoagulation?
Yeah, so actually this is a bit of a misnomer, and I think that Iridex is trying to work on that. G6 is the name of the machine. So G6 is actually the unit, and when you use the G6, you can use the G probe, which is the continuous wave diode, or you can use the MP3 probe, which is a micropulse diode. So all lasers are a diode on that G6 platform. You can use it in a continuous wave mode, which is the G probe and the G probe illuminate, or you can use it MP3 probe, which is the micropulse mode. Micropulse is an amazing tool to have. I think the discussion was in the past, micropulse versus continuous wave, but I think now, with the tendency of the slow burn technique, it kind of leveled up the field. I think with a slow burn technique, you can get good outcomes with a good safety profile that is maybe comparable to micropulse treatment.
We have one last question, I would say, but I would like to pose it to all three of you. And I will start with Ronald, and then we go to Stella and Ziad. There are so many different variations when you are using lasers, and everybody tries to innovate. So a question that comes is, would you actually use a cyclophotocoagulation with a diode in one hemisphere, 180 degrees, and consider doing a micropulse in the other or the other 180 degrees of the same eye? Have you ever done something like that, Ronald?
No, because I think if you want to perform a laser procedure and especially a ciliary body procedure, I think you can make a very good decision in if you want to prefer only micropulse treatment or continuous wave mode, and you can adjust your settings towards it. So combining both in one eye during one treatment, I never do it.
What about Stella?
So I agree with Ronald. So the concept of the micropulse laser in general is not to slowly cook. It's to prevent any cooking, because in between the spikes, let's say in the increase of the temperature, you have enough time to cool down any tissue. So actually you don't perform any damage. So that's something like a concept completely different. So I agree. The cases that are more advanced, that needs the, I would say, continuous laser, probably need to be treated with a continuous. Those that are at the beginning of the disease can be treated with a micropulse laser. So different conditions.
Ziad, one last question. Despite having different indications, probably, SLT versus micropulse, what is more effective?
Well,
Are you
to be
asking?
honest, sorry, was someone answering the?
Go ahead,
No,
go
go
ahead.
ahead. Go ahead.
Yeah, so I'm a big SLT kind of guy. Maybe I will try to venture into MLT in the future. I think the majority of the evidence out there is backs up the use of SLT. So far, if you look at the major RCTs in the literature, MLT is probably a technology that will be investigated much more in the upcoming years, and I'm waiting eagerly to see the result of those trials and studies to see if I'm gonna make a shift. So I take this with a very open mind.
Very good. Okay, last 30 seconds. Ronald, somebody's asking for your email address. Maybe you would like to answer that. Ziad, somebody is asking for your private phone number. You might like to answer that as well.
Who's asking for it?
With that, I would love to conclude this fantastic webinar. I really enjoyed it. Thank you very much for all the insight that you've given. Thank you for Iridex for a very well organized from every aspect webinar. And above all else, I thank all the participants for being with us and have a beautiful rest of the day. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, and bye.